So first case, this one will be a 30-year-old female patient with vague abdominal pain and normal ultrasound. Nothing pain, generalized ill health, whatever. So MRI was ordered for her.
MRI, axial sections through the abdomen.
Good.
T2.
T2, fat sat, low non-fat sat?
Fat sat.
Fat saturated. Good. Showing.
Showing the kidneys probably normal, no specified lesions, no collections. C.
Okay.
T2. Seems to be normal. Spleen, normal.
So normal liver, normal spleen,
Normal kidneys.
normal kidney. Anyway.
T1.
T1, fat sat, low non-fat sat?
No fat sat.
Good. Showing.
Talking about because the stomach is markedly dilated.
Okay.
So we should check for the stomach outlet obstruction causes.
So dilated stomach. Check for outlet obstruction. Check. Is there any cause of outlet, gastric outlet obstruction? So let's take it from another perspective. What are the radiologic features of gastric outlet obstruction?
Distended stomach.
Okay. What else? Best stomach distended? Only stomach will be distended?
Duodenum, maybe.
The duodenum is the outlet.
Antrum.
Okay. Is there any duodenal distension?
No,
No signs of duodenal distension. Other than duodenum, what else should be distended in cases of gastric outlet obstruction?
antrum, pylorus.
Okay, هكون gastric. غيرها. Esophagus will not be distended?
Yes.
Okay. زين. Is it distended here? Esophagus? It's completely collapsed. You can't even barely see it. This one, you see the esophagus? Yeah, this, exactly. This one. Then, high second. Third, what are the radiologic features of gastric outlet obstruction? Distended stomach. Distended with what?
Fluid.
Fluid. Okay. Is there any fluid in the stomach?
No.
Is there any fluid? No. Okay. Fourth, what are the clinical features of gastric outlet obstruction?
Vomiting.
Vomiting.
Distension.
Okay. الكلينيكال الهيستوري اللي اعطيتك اياه شنو which I gave you what was it
30 years old female
mm-hmm.
with vague abdominal pain.
زين so there was no history of vomiting so you should not think of gastric outlet obstruction زين but still the stomach is distended so what are the contents of the distended stomach let's see them on T1
heterogeneous, but prominent, predominantly high point.
High point. It's good. Heterogeneously, predominantly high point test. Excellent. On T2,
Same.
it's hyper intense. Heterogeneously, prominently high. Is it? Do you see the tiny black dots?
Yeah.
There. On the T1, are they present or not?
Yes.
Okay. So there are tiny black dots within it that are present on T1 and T2. They don't change signal, suggesting that these are what?
Calcifications.
Calcifications in the stomach?
Maybe
Or
foreign bodies.
Or
Blood.
or blood? Hypo?
The high. Calcification.
Blood or air bubbles. Air bubbles are way more common to be seen in the stomach than probably any other organ. Okay. So is heterogeneously, let's say, the heterogeneous signal intensity filling the stomach with air bubbles with no signs of gastric obstruction in a 30-year-old female with vague abdominal pain? Most likely it will be biswar. Whether it's tracheobiswar, phytobiswar, I don't know what biswar, it's not my concern. It's a biswar, okay? And that's why the ultrasound was normal. The ultrasound, it's very not difficult. It needs a big experience to diagnose biswar by ultrasound. First of all, you should look at the patient. Most of the patients will be a little bit psychologically let's say, inappropriate in some way. Most of them are females, not all, most. Most of them will have bad hair because they eat it. They pluck it up. You'll see the hair is, I don't know, ugly looking. Okay. And it will be, if you see on the coronal here, this would be very typical. It's like a cast. It takes the shape of the stomach perfectly because over the years she's eating, I don't know, hair or what. Most commonly in our part of the world, it's hair. There are other like phytobiswar and I don't know what biswar. So it's typical biswar, but on an MRI. Usually we are used to see it on a CT scan. Okay.
هذا ما يسوي vomiting?
It might, but here it was not. Sure, it might. Why not?
Nice.
Okay, good. Hair between the hairs, it traps air bubbles. يعني, it's not a mass. Mass, soft tissue mass, there will be no air inside, but it's a foreign body. Anyway, this is a 25-year-old male, okay, with knee pain. That's all the history that I have, صراحة. But can I just a second? Yeah. So knee and hip MRI was ordered. It's big. Knee pain, lower limb pain, something like that. Well, بالحقيقة, to be honest, هو knee MRI, but I moved forward to the pelvis. I recommended the pelvis. So what do we have here?
This is proton density
Okay, excellent.
of the knee
Fat saturated.
proton density of the knee joint. ICL, there is high signal in the ICL,
Okay.
and seems to be
Partial tear, probably high grade partial tear.
signal intensity in the distal femur, the lateral condyle. This PCL is normal. there's multifocal high density signal in the bone in both femur and proximal tibia.
Okay. Suggesting what?
Suggesting bone contusion or
أحد يعرف هاي الساين؟ Anyone knows what's the name of this sign? بس move through the slides. Scroll. What is the name of this sign?
subchondral.
Osteochondritis. Does it? There is no bone loss, so it's not an osteochondritis dissecant.
Early grades, maybe.
دقيقة, just a second. أوفي الماوس لحظة بس. Scroll now.
Here also.
Okay, on the TV also. So, now what? What about this, the metaphyseal region abnormality? Do you see it? This is an abnormal area. So it's and which is, this is geographical. This is in يعني شو نقول serpiginous. So it's, what's the name of the sign? It's Chinese letter sign. Chinese letter sign. It's a sign of bone infarct. Okay. So probably it's not as big as we used to see it, but still it is bone infarct. خصوصا يعني especially that we have not explained the pain. I mean, the medial meniscus is good, the lateral meniscus is good, the patella is good, the ACL is good, the PCL is good. We have no explanation for the pain, so this can be a very good explanation for the pain. Now, the patient has bilateral limping. Okay, so we move to hip joint. We did a hip joint MRI to see other. What's the sequence? This one. This is T2. Coronal. Fat saturated, low non-fat saturated. Non-fat saturated. Showing
T2 still
T2 square.
showing abnormality of the bilateral low signal intensity of the femoral epiphysis more on the right side with the surrounding joint effusion. So, the head of the femur
Is
showing geographical heterogeneous intensity, more hypo-intense on both sides with irregular articular surfaces,
suggesting
of the necrosis. But
شنو necrosis?
osteonecrosis.
Avascular necrosis of the femoral head bilaterally. Which grade?
This grade.
Which one is grade? On right side, which grade? There's cortical irregularity on the right side, suggesting grade. Cortical irregularity, grade 2. Grade 3. Grade 4, total collapse. On the left side, it's grade 2. اكو signal intensity with preserved outline.
On the right side less than the left side?
Grade 3 on the right side, on the left side, grade 2. The right side is more.
بالجريد 2 اللاين ولا يعني البونينج بداخل same density of the bonding
Density, high intensity.
same intensity بس بالجريد 3 يصير hypo.
اي ماشي اوكي من اكو cortical irregularity. When you have cortical irregularity, this is grade 3. من صار complete collapse of the femoral head صار رفع. Okay, when it's preserved the femoral head outline with linear hypointensity serpiginous this is grade 2. When it's just bone marrow edema, this is grade 1. Okay, so anyway, it's grade 3 on the left, grade 2, 3 on the grade 3 on the right, grade 2, 3 on the left. There. Now we are going in a very nice direction. Summarize your findings.
There is
Summarize. Key findings. We have
bilateral femoral head heterogeneous intensity, mostly going with the avascular necrosis.
bilateral vascular necrosis and
bone infarction of the
bone infarction. Okay.
the distal.
بعد.
Any finding?
Okay, let's do it. يعني take it from another perspective. Can you put these together? Why this 25-year-old healthy man who is muscular and is good shape? Huh?
Is there
no.
The drug taking?
Can you put them together? What's wrong with him? So transplanted kidney. Transplant kidney, immunosuppressant, steroids, ما أعرف شنو, led to bilateral vascular necrosis and ماشي.
هو هنا
Okay.
المشكلة مالته.
What do you think this is? You should try to see the scrotal sac. Let's see on the T1. This is the lesion. It's iso and hyper, and it's located, and this is the other, what? Testicle. So he have, in addition to all of that, what? Bilateral, undescended testicles in a 25-year-old male, making him at high risk of seminoma, of germ cell tumor. Okay? It's empty because both testicles are up. It's collapsed. ها. يعني إذا تريد بالكورونا يمكن أوضح، أو خلينا نشوف هذا الكورونا راح. بعد سكروتم it's empty. هاي هنا سكروتم. Nothing. هذا البينايل. This is the scrotum. Okay?